I'm very happy to be talking to you today about the potential use of monoclonal antibodies for HIV and the lessons we've learned about the use of mAbs for COVID-19. These are my disclosures. My talk will be in two parts. I'll discuss the potential for broadly neutralizing antibodies to be used for treatment and prevention of HIV, and then what we've learned from the use of monoclonal antibodies against SARS-CoV-2. Let's start with a review of bNAbs for HIV-1. Broadly neutralizing antibodies are human monoclonal antibodies able to neutralize a wide range of HIV-1 isolates. They target the HIV-1 envelope and enhance various effector functions, including complement-mediated lysis of virus particles, antibody-dependent cellular cytotoxicity and phagocytosis, and they may increase HIV-specific immune responses. In addition, these antibodies can be genetically engineered to combine multiple specificities into a single molecule and to extend half-life. These antibodies target different domains on the envelope glycoprotein, including the CD4 binding site, the V1-V2 loop, the V3 glycan patch, the GP120-GP41 interface, and the membrane proximal external region of GP41. There are several potential uses of bNAbs in the treatment or prevention of HIV. One can imagine bNAbs being added to an antiretroviral regimen in order to intensify therapy, or perhaps to create a long-acting regimen in combination with an injectable small molecule. They might be used in place of daily oral therapy as long-acting agents themselves to maintain viral suppression. In highly treatment-experienced patients with no other treatment options, bNAbs might substitute for small molecule antiretrovirals. And in people without HIV, they might be used for prevention, a topic to be covered in the subsequent talk by Dr. Carlos Del Rio. This slide shows a phase 2A study of VRC01, one of the very first bNAbs to be developed and brought into clinical trials. You can see there was a prompt decline in viremia after administration of the antibody, but then also a relatively rapid rebound in the majority of the participants who received the antibody. This rebound was associated with the emergence of drug-resistant virus, antibody-resistant virus, as seen by the increase in IC50 and the emergence of mutations that correlate with the loss of neutralizability of these virus isolates. In addition, when people who were already suppressed on antiretroviral therapy received VRC01 and then that therapy was stopped, there was relatively prompt rebound in all participants, with just one or two participants showing a modest delay in rebound. And once again, this rebound was associated with the emergence of resistant variants of the virus. You can see these oligoclonal variants that emerged with high IC50s compared to the IC50s of the viruses that existed prior to treatment. In a study in which our own group was involved in, led by Roger Shapiro, we treated infants who with HIV in Botswana who had been identified with HIV within a day of life and received small molecule therapy, combination antiretroviral therapy within the first day or two of life, and after being suppressed for several years, were then given a combination of the long-acting form of VRC01 plus a second antibody directed against a different epitope, 101074. And this combination of antibodies was able to maintain viral suppression when the combination antiretroviral therapy was stopped in 44% of the infants. The ability to sustain suppression was reasonably well correlated with the presence of a susceptible virus as judged by phenotyping of single genomes amplified from latently infected CD4 cells. There's a big challenge, however, in finding the right combination of antibodies that could neutralize the vast majority of antibodies. In a thought experiment done by Wog and colleagues, if you combined the best possible antibodies against in different combinations against a wide variety of viruses based on the known susceptibility of viruses from different subtypes to each of these broadly neutralizing antibodies. You can see that combining two antibodies, the best two antibody combinations, could provide neutralization of up to 80% of viruses if you asked that only one of the antibodies retain activity. But if you wanted both antibodies to be active, then less than half were neutralizable at the lowest concentrations, and only 80% could be neutralized even up to an IC90 of 10 micrograms. If you allowed for more combinations of antibodies, you could get to a better percentage of coverage. But even with 3 antibodies and asking that only 2 of the 3 be active, to get to 90% coverage, you had to have allow an IC80 of up to 10 micrograms per mil, which would require much higher trough concentrations. Same was true even if you could combine 4 antibodies. So being able to provide coverage of virtually all viruses is going to be a nearly insurmountable task. Now, recently, data were presented on a study that used a combination of 2 broadly neutralizing antibodies, one directed against the CD4 binding site, one directed against the V3 glycan. This second antibody was actually a derivative of the 10-1074 antibody we used in our infant study. These antibodies are now named teropavimab and zimlirvimab, and they were given together with the long-acting capsid inhibitor lenacapavir. These antibodies in combination are estimated to cover at least 50% of clade B viruses with both antibodies being active, and 90% being inhibited by at least one of the antibodies. When these combinations were administered to 20 participants, 10 of whom received lenacapavir plus the antibodies at a 10 mg per kilo dose, and the other 10 at a higher dose of the combination mAbs, you can see that 18 out of 20 were able to maintain viral suppression. To identify these 20 participants, a large number of people needed to be screened in order to identify participants whose virus was susceptible to both of the antibodies. One of the participants counted as a failure actually had withdrawn prior to week 26, but there was one who did have virologic rebound at week 16. That person's virus is still being analyzed to see whether resistance to the mAbs and to lenacapavir had emerged. Well, let's shift now to talk about what we've learned about the use of monoclonals in the treatment of SARS-CoV-2 and why this serves as a cautionary tale. SARS-CoV-2 has undergone extraordinary rapid diversification, much faster than imagined, because of the low intrinsic error rate of the SARS-CoV-2 RNA-dependent RNA polymerase. However, the intrinsic mutation rate of the enzyme is only a part of what explains the emergence of viral variants. If you have a very large number of transmission events, then that can compensate for the low error rate. And since we've had tens of millions, if not hundreds of millions of infections with SARS-CoV-2, that means that effectively there's been a much larger pool of virus to select from, despite the fact that the error rate of the SARS-CoV-2 polymerase is a fraction of the error rate of HIV reverse transcriptase. And this variant selection occurs with each transmission event as well as within individual hosts, where variants evolve to escape natural and vaccine-induced immunity. In addition, persons with prolonged shedding of SARS-CoV-2 may serve as a source of viral variation. Plasmodium and etesevimab were the first combination of antibodies shown to be effective in reducing the risk of hospitalization when administered to symptomatic individuals with SARS-CoV-2 infection as outpatients. You can see there was a 70% reduction. This was highly statistically significant and led to the emergency use authorization of this combination. In addition, bamlanivimab was shown to prevent the acquisition of COVID-19 in nursing home settings in people where there had been an index case, and those who were not yet infected were randomized to receive placebo or antibody, and was highly effective at preventing the occurrence of COVID-19 in those individuals. However, by the time these data were presented, the virus had evolved and bamlanivimab was no longer effective against the then circulating viruses. And that story is told in the next several slides. We know in early 2021, where the original strain was still circulating, it was then displaced first by alpha, then by beta and gamma, and eventually by delta, which came to predominate in the second half of 2021. These viruses were no longer susceptible to the initial antibodies that had been developed for the treatment and prevention of COVID-19. Delta itself was then displaced by Omicron in the late 2021 and throughout 2022, with successive emergence of subvariants of Omicron running from BA1 and 2 through BA4 and BA5, and now more recently at the end of 2022 and the beginning of 2023, the BQ1 variants, so that today what we see is BQ1 being displaced by XBB. This is important because the XBB is resistant to all of the antibodies that are available, including imdevimab and casirivimab, even when given in combination or tested in combination. These are the components of REGEN-COV, resistant to sotrovimab, resistant to bebtelovimab, which had retained some activity against the BA2 isolates, as well as resistant to tixagevimab and silgevimab, separately and in combination. These are the components of Evusheld, which have been used for prevention of infection in severely immunocompromised individuals. All of this suggests caution in our hopes for the use of mAbs against HIV. We know that adequate coverage of HIV diversity will require administration of multiple mAbs. Viral evolution and emergence of variants resistant to SARS-CoV-2 has sharply limited their utility against COVID-19, so that we now have no useful antibodies to use for the treatment of COVID-19. In the case of HIV-1, it's conceivable that mAbs may be more successful in maintaining than establishing suppression, as we saw in the lenacapavir study. But the need to perform susceptibility testing prior to the use of a mAb, plus a long-acting antiretroviral agent, poses a substantial barrier to their use. Simplifying administration and reducing the cost of goods will be essential to ensure equitable access to mAbs on a global scale. Thanks for your attention, and I look forward to the discussion.